Yes, I was getting ready to do that and we are unmuted now. I hope
Okay.
everybody online can hear.
Everybody online will be in the dark about who this is speaking to them. So I am so happy to be here with you all, and I absolutely mean that from the bottom of my heart. You are my people. I love mental health boards, and I want to say a huge welcome to all the new mental health boards in the room. I have been working with mental health boards. I think Livingston County was the first mental health board that I worked with in the late aughts, as they call it, and in 2010 on a large Illinois Children's Healthcare Foundation grant, which really got me started in this work and made me a believer in the public health model of children's mental health. I mean, you can read it in the research that it's the thing we ought to be doing, but to actually see it in practice and see an entire system of children's well-being emerge. It's really, really exciting. I chose to put up this whole theme around the Northern Lights. So how many of you in the room have seen the Northern Lights? I'm just curious. Okay, that is amazing. It's on my bucket list. I want to someday see the Northern Lights. And I'm on these Facebook pages where I'm seeing there are Northern Lights happening in, you know, the US, the lower 48. And so it's like, I know they're out there. I see the pictures on Facebook, but they seem mystical, magical, almost like I can't believe it until I see it. And so I picked that for this theme for today, because I think that's the way it is about a working children's mental health system. It's like we believe it is possible, but it's this sort of magical, mystical thing that feels a little bit out of reach, and we don't know if we'll believe it until we see it. So I'm going to launch into talking with you today. I have to see if this, if our little clicker is going to work for us. There we go. There we go. So I want to start out by asking you, if you're willing, to close your eyes for a minute and think about 8 to 10 years from now. You've just gotten up on a lovely day and you've gone about your day taking in information about what's going on in your community, however you choose to do that. A cup of coffee and the internet, going out for a walk, whatever. And you see something as you're engaging, or you hear something as you're engaging, that just floods you with a bunch of gratitude. You in that moment know that the children of your community are thriving. They're flourishing. And you feel this wash of gratitude because you know you had something to do with that this vision has come to be a reality. I'd like you to open your eyes, and if you would, jot down what it was that you saw that gave you that feeling and the knowing that it's a reality. This really is the Northern Lights. These kids are really flourishing in my community. So take a couple minutes and jot a few bullets down about what you saw in your mind's eye that led to you feeling this rush of gratitude and satisfaction about the children flourishing in your community. All right, I'd love to hear, what's one thing that you wrote down that told you that the children in your community were flourishing? How did you know? What did you see? Yes.
Children playing together at the playground.
Seeing some children playing together at a playground. Beautiful. What's your name?
Kelly.
Colleen, and where are you from?
Public Lights.
Nice, I've heard of that. So Colleen, nice to meet you. So Colleen sees children playing in a playground, at a playground, and knew, this is beautiful. This is the Northern Lights. Back in the back.
I saw a new youth center that had opened up with kids outside and doing community service.
Oh my gosh, a youth center with the kids outside doing community service. Beautiful. Somebody else had their hand up. Over here. Yes,
I saw the kids outside playing too, and there were no adults.
there were no adults, and that felt good. Nice. Why did it feel good?
They were safe.
Yeah. Yeah, they were safe. They were safe. In the back.
So mine was also there playing outside here.
No phones. No TikTok, no social media. The kids were outside enjoying playing with each other and nature. Beautiful. I want to hear another one. Yes.
I wrote kids initiating and organizing on their own to help someone in the community.
Wow. How did you know it? Was there something that you saw?
I just assumed it'd be like a local story I read or something.
Oh, like you saw it on the news, a public interest piece about how these kids were helping. Nice, nice. I saw another hand. Yeah.
I read in the paper about a student-run mental health club at school.
A student-led mental health club at school. Nice. You know, you've got the less stigma, right? If you have the youth running a group. Yeah.
I wrote down NAMI education.
Okay. What do you want to say about that?
I know our local NAMI has started a program in the schools called Ending the Silence.
Mhm.
And that's like something they've been trying to do for a couple of years.
So you saw Ending the Silence being widely used and celebrated within the schools. Excellent. Ending the Silence is a suicide prevention program.
So I have an area that people just throw out the trash. And so the kids are just picking up the trash and wanting to have their actual neighborhood be clean and safe and, you know, they have a sense of pride in where they live.
Wow. And so empowered, right? That they believe that they can make a difference. They're picking up the trash in the neighborhood. Yes.
Jotted down community piece.
Community peace. What did you see that filled you with the sense that there was community peace?
This community or nationwide movement of peaceful behavior. Smile. Greetings.
So a nationwide movement of peaceful behavior, smiles, greetings, kindness, right? Okay, so now we're going to do this again, but we're going to think just 3 to 5 years from now, okay? So 3 to 5 years from now, you're going about your day. Again, if you're comfortable, close your eyes. And you see some things that give you a clue that you're on the right track to being where you visualized your community in the 8 to 10 years from now. So how will we know in 3 to 5 years that we're on the right track? All right, let's hear some. Go ahead, Chris.
As I see like kids playing activities, whether it's sports or recreational, whatever, kids on the sidelines starting to come in to the groups or to the group. I mean, like they're wanting to join, but it's coming. I mean,
Okay. So you're seeing the sort of outliers, the
Yes.
kids that might be on the sidelines, having a desire and having some success and moving into joining with the rest of the kids. Nice. That's a foreshadowing of a public health model right there. Who else had an idea of something they saw that they thought, oh, we're on the right track? Yes.
Children and youth's opinions about what is good for them being listened to as opposed to adults deciding what is good.
Wow. So youth voice. So youth expressing their needs, their thoughts, their feelings, and being listened to by adults. and having, being empowered, having an influence on what's being designed for them, right? Yeah, I love that. And there were several people mentioning things like being student-led, right? That young people are feeling empowered to show up fully. Let's go with one more. Oh, two more. Go ahead.
I was just gonna say, a school cafeteria where you don't have the principals on four corners with the kids in the middle being observed and not able to socialize or do anything for the front of.
Wow. Wow. So Deb was saying that a cafeteria where you didn't have the principals stationed at the four corners, kind of keeping things shut down and controlled for fear that the kids might not be safe, right?
My thought was, fathers returning home. And, not just the home as in the house, but returning to home as in their role in the community, in church, in the areas of the community.
So fathers returning home to the role in home, church, family, and community. Beautiful. Yes.
Mental health first aid being required in school.
Mental health first aid being required in school for the students. Mhm. And there is a program called Teen Mental Health First Aid as well, that is being used in a number of different schools. Beautiful. Okay, so you all can visualize the Northern Lights. You know they're there. It's possible. You can imagine it happening. And now we have to figure out, how do we get to that 3 to 5 year picture? How do we get to that 8 to 10 year picture? So today, we have a very packed agenda. And what I want to say at the outset is, if you try to remember and digest everything that I'm talking about, or even think, oh, these are all the things our mental health board should be doing, you will be completely overwhelmed. So what I tried to do today was pack the agenda with basically a buffet. This is like a huge smorgasbord. And you all know from your experience of going to a buffet, although I don't know how many of those survived COVID, but you know the dilemma, right? You come up with your plate, and if you just start taking some from everything, you're a quarter of the way through the buffet and your plate is full, right? Some people approach a buffet where they walk along and they see what all is available before they start filling their plate. And I'm going to encourage you to kind of do the latter today. But so I'm going to talk about these 7 topics that I have up here and kind of just tell you what I've learned along the way with regard to these 7 things, and the fact that I learned that these 7 things are important. And as you go along, I want you to walk away with maybe no more than 3 ideas that you think are actionable that you want to go try to do. And this PowerPoint is going nowhere. I mean, you're going to have access to it. You'll even have access to this recording, so you could listen to it again. Try not to get go down a rabbit hole. Try not to get too far in that you are overwhelmed by the amount of information that I'm going to share in this day. Okay, because this is a buffet. It's going to be at least 100 different ideas that you could say, oh, we could do that, right? So be selective. I will say also that if at the end of the day, we say to ourselves, gosh, there's a bunch of us that are really interested in one of these things. Like, this is where we have readiness. This is where we have urgency. We want to do this thing. We could have our own professional learning community of all of us who are wanting to do that thing together and support each other down that path. So anybody who knows me knows that I'm actually not going to read all those to you. We'll come to them as we go. I firmly believe that the public health model is the only viable path forward to turn this ship around. Turn the ship of children's mental health needs around is the public health model. So I'm going to talk about it in much more depth today than I usually do. And the totality of it, right? The power of it. So if you want, if you've printed out your handout and you want to stay on this triangle as I move ahead, please do that because I'm going to be referencing it as I move along. How many of you feel like you've got a really firm handle on the mental health model? Just want to see. Okay, well, I'm glad we're doing this then, because it's the answer to our path to the 3 to 5 year and the 8 to 10 year. All right. So the public health model is this triangle that I just shared with you. And the big triangle represents all the children in your community. So that triangle is every kid born in your township, born in your community, and their mental well-being, okay? So when we talk about a tier 1 or a universal intervention, it's something that we think every kid ought to have. So there are some communities that send every kid that's born in their county home with a basket of books from the hospital. That's essentially a tier 1 literacy intervention, right? It goes to everybody. You don't have to have any special characteristics to get the basket. It goes to all. In schools, tier 1 could be things like, a social emotional learning curriculum that every teacher does. That would be a tier 1 intervention. They are costly in the sense that we have to get them to everybody. So they are a broad intervention and a general intervention. They are very hard to do if you're, having to prove how successful they were. Because if you have a universal suicide prevention program and nobody kills themselves, how do you know, right? We don't have the luxury of these video, movies where you can travel back in time or forward in time and see how our actions impacted. So the universal interventions are costly in the sense that we need to get them to everybody, but they are super, super powerful. Our intervention goes to 100% of the kids. So tier 2 is, actually, I think I'm going to go back. So I don't know, I'll keep it up. So tier 2, as you go up the triangle, it's a smaller portion of the kids. And tier 2 are kids who are vulnerable to developing a mental health disorder in some way. So sometimes we identify people that are falling into tier 2 because of where they live, how much money their family has, the fact that they have a learning difficulty. There's things that make groups of kids more vulnerable to developing a mental health problem. And we can just look at their needs as tier 2, but oftentimes we actually do something systematic to try to identify who those kids are that need something more than what everybody's getting. And traditionally we call this screening. So some kind of systematic way that we identify a positive screen meeting a greater need for more services. And that takes us to tier 2. Now, in a public health model, depending on whose literature you're reading, there's like 15%, maybe 20% of the kids, they're going to need more than what you're doing for everybody. So that's tier 2, okay? At tier 3, we've layered on, okay? So the kids are getting what everybody's getting, then they're getting what the kids who are vulnerable are getting. And at tier 3, we've got kids who needed more than those 2 levels of intervention, and they have developed a disorder, some sort of condition that needs like one-on-one therapy or the like. Now, there's about 10% in a sort of traditional healthy public health model, about 10% of kids who might need individual therapy. And then I have added a 4th tier. Not everybody does, but a 4th tier for kids who not only need individual therapy, but but they and their family are potentially getting served by a lot of different agencies. They've gone into the hospital, they've come out of the hospital, they're involved with the courts. So you get the idea. This should only be about 2-ish% of kids whose needs are that far, and that's why it's a tiny triangle at the top, okay? Our goal with the public health model is to keep the tier 3 and the tier 4 at the top of the triangle as small as possible. Because the further up we go with the triangle, the more costly the interventions are and the fewer resources we have, right? Because the services are much more intense, they're more frequent, they are longer in duration. So the idea with the public health model is that we match the level of intervention, the frequency, the intensity, the duration of the intervention to the frequency, the intensity, and the duration of the kids' needs. Does this make sense? So the idea is we keep as few kids and in the bottom tier 1 and tier 2, the most number in the tier 1 and tier 2 that we can, and as few as possible up there in tier 3 and tier 4, because those are intense interventions. Now, the reason that I have these two, when we put my PowerPoint onto the Mac, my highlighting disappeared. So I had highlighting on tier 3 and tier 4. And the reason that I did that is because traditionally, most mental health boards put their money there. They put their money there. The problem right now is not that, we don't want to fund those programs, but we have, according to various, counts, about 40% of our kids meeting the diagnostic criteria for anxiety or depression or other mental health conditions. So when you think about that triangle, we're supposed to have 10% at tier 3. We've got 40% at tier 3. We don't have a triangle anymore. We have sort of this box, if you will, because we have so many kids at the top that are needing services. So we have to have a focus on the tier 1 and the tier 2, because we got to get our numbers down. It's not tenable. It's not sustainable to try to meet with individual therapy the needs of 40% of your kids. Okay? It's just not possible. Those are not part of the Northern Lights. We want to, if you think about, like, say you have a grade of 100 kids, and if you're thinking really practically about this, you have a grade of 100 kids, 80 or so of them, you should just be able to do whatever you're doing in the classroom or in the after-school program, whatever. And then do something more for about 15-20% of them, do something even more intensive for about 10 of them. And then there'll be about 2 or 3 that need you to pull out all the stops, right? Yes.
Why is there what's your speculation why there's a 40% concentration? Why did that happen?
The main working hypothesis, is that during COVID, there were a lot of these tier 1 and tier 2 activities that were already being done in schools and things like that weren't done. So they weren't done during COVID because everybody was just surviving. And in addition, kids were having lots of stress. A lot of them were in environments where their parents were super stressed, right? Even now, the number or the percentage of adults that have diagnosable mental health conditions is much greater. So in the past, a kid who needed help, who went to an adult, 9 times out of 10, they're going to get somebody who is not also suffering from their own mental health diagnoses. Now, 7 times out of 10, they're going to find an adult who's not suffering from their own mental health needs. So that's part of it. So the stresses were on everybody, not just the kids, and they didn't get the part of the triangle that they were getting before. And now that everybody's back from the shutdown, there are so many kids in that tier 3 and tier 4 that everybody who's at all a mental health provider is focused on keeping those kids from killing themselves or other people. That is sort of the crisis that we're in right now. So schools are just keeping kids stabilized from 8 to 3. They're just keeping kids stabilized. So there are lots of like drop-in centers and things like that to just try to help kids be stable and get through the day. And there's not a lot of intervention, actually. And intervention meaning you're doing something to improve their skills and get them back into the tier one. There's not a lot of that happening. It's getting better every day, but in the meantime, these kids that we were trying to keep out of tier 3 and tier 4 have been continuing to kind of slide.
So the implication is over time, this will be cured, that there's gonna be a reintegration of this balance.
Only if we can start doing tier 1 and tier 2.
Those are not ongoing at this point.
It's a struggle. It's a struggle because of workforce shortages, both in school and in community agencies. So everybody who has mental health training is largely spending the bulk of their time stabilizing the kids who are struggling the most. Yeah, it's, I don't want to start with a dim view here, but that's where we're at, right? This is where we're starting, but we're heading to the Northern Lights. We know it's possible. Yeah.
So this is the first pandemic we had, going back in the early 1900s. Is there any data from that period that would indicate how children responded mentally, mental health?
I have no idea. I have no idea. I don't know the research on that. It'd be an interesting question, though. I think there's a lot of things that are different now than during that last pandemic. There are a lot more resources on the internet, but there's a lot more difficulty as a result of really being connected to people. We're connected to people in more ways than just our health, right? We learned that we're all connected during COVID in a physical way, but we're learning that our connections to each other can be a blessing and a curse, right, through the internet.
Yep.
All right, I want to move, actually, what I'd like to do, yeah, I'm going to go ahead for a couple more slides here. So I'm laying out the totality of the public health model, right? So you got that there's these 4 tiers, and there's a bunch of glue that holds that together. So at each age, there's essentially a completely different system in your community for serving the children of that age. So there's an entire group of providers at 0 to 3 that are not the same people that are working with kids at 3 to 5, that are not the same people that are working at kids from K-12, and not the same people that are working with young people from 18 to 25. I see some nodding. So one of the things we need to recognize is that those transition points can be huge, the proverbial like crack that kids are falling through, right? Between these systems. So we want a seamless system as kids grow up from one system to the next, and recognizing that they're sort of vulnerable to getting dropped through the crack when they shift from high school to transition age, for example. And so some of our interventions, we might be thinking about tier 2 interventions around the times of these transitions, right? We may also think about working on our system to make sure those transitions are a really nice, warm handoff as the child ages. We also yearn for coordination. Everybody talks about it, right? People working in silos. We've heard that 1,000 times. We yearn for coordination so that we don't have, 14 agencies doing one thing and, none doing this other thing that we need to have done, etc. And so one of the things that we could, as mental health boards, do is fund coordination. Nobody wants to fund coordination. So I'm going to give you a couple of examples here. At tier 1, remember, and I talk a lot about schools because I have spent a lot of time in schools. So you think about tier 1, a classroom intervention. Teachers are doing their own classroom interventions, hopefully with a curriculum that has some support behind it. And then you have a whole bunch of lessons or curricula that are available in the community. And people will come into the school and do Ending the Silence, for example, with the students in the school as a tier 1 intervention. Everybody gets it. And in most communities, these are not coordinated at all. It really depends on who the principal is, who the superintendent is, whether those programs get in the door. And so an example of an intervention that a community I'm working in created is a tier 1 resource guide. So it's got all of the classroom interventions that the school is providing free of charge, all on one nice little handout. So schools can actually know what's the menu of what is available to us. So a school can say, you know what, we want to take substance abuse prevention really seriously. And so we're gonna look at what we've got inside the school, what we've got outside the school, and organize ourselves. So we wanna say, hey, there's intervention available. We want kids to get it at 3rd grade, 5th grade, 7th grade, and 9th grade, right? And they can look at the menu and access those services in a coordinated way. What exists now is like, in 6th grade, and 6th graders getting 3 substance abuse interventions, and the 3rd and the 5th and 7th and 9th aren't getting any, because it's not coordinated, it's not thought out, it's not systematic. And so that resource guide is a lovely tool. The other thing that it saves is what I call the telemarketer at dinner time, which is all these agencies that could be doing these wonderful interventions, but they're out marketing to try to get their program into the schools. And so if all of them are bringing the same menu, then the principal doesn't have to sit with 12 different agencies. They have one. Another intervention, looking at tier 4. At tier 4, all of your communities have some entity funded by the state for a program called Pathways to Success. And it is designed around a system of care model, which I think probably most of you have heard of. And the system of care model is all about how we coordinate for kids who are getting all of these intensive services at the tier 4. Okay, so that's an example of the powers that be understanding that when kids are at that top of the triangle, that they need an agency or agencies to actually wrap around with the family instead of that mom or dad having to have a degree in project management just to get their kid, some help. So that's horizontal coordination. Vertical coordination is that as the extra interventions are layered on, right? A kid is at tier 1, but now they need tier 2, or now they need tier 3 services, that we're coordinated that way. And so an example of a tier 3 intervention, I'm just going to stop and highlight this one for a minute, because it goes to your point about why do kids need what's going on right now. So we all went through a bunch of adversity or chronic stress or trauma, whatever you want to call it, over the last few years. And what we know about experiencing trauma is that we have certain needs that get exacerbated. We need the thing so much more when we go through trauma. And one of them is connection. We need connection more when we've been through adversity. And you saw it. And the problem with the pandemic was people were isolated, and they were also having a heightened need for connection at the same time. Secondly, we need a sense of control. And I used the word empowerment several times earlier. We need to know that what we are doing is actually impacting our world, that it's that we can influence what's happening to us. And the pandemic just yanked control from us at the very time that we were responding to this trauma and having greater need for control. And the third one, I use the word capacity, but it's basically being able to regulate and manage what's going on inside of us, our emotions, our own internal landscape, so we don't feel crazy, right? We had a whole lot of emotions through the pandemic, and a lot of kids do not have the capacity to manage those things. A lot of adults don't either. Okay, and that's a heightened need after going through what we've all been through. So what I've done with a number of different communities is design a tier 2 intervention that targets these 3 things, right? Helping kids build their relationships and adults build their relationships, empowering interventions, and so on. At tier 3, So at tier 3, this is when a kid needs actual therapy, right? They actually need a therapist. You all know, if you've had anybody in your family, you try to go get them therapy, you gotta know somebody, you gotta stand in line, and it can take months and months anyway, even if you have really good insurance. So one of the programs, a lot of the schools are trying to find like referral programs that will help them get kids connected. And Carasolis is one that a lot of schools are using. And another one that's really popular around the western suburbs is Referral GPS. And what Referral GPS is doing is not only getting people connected to therapy, but they're also allowing schools to create their own little savings account of money so that they can connect kids to any therapist, really. And the first 8 sessions will be paid for. If you think about it, it's genius, right? Because you have all these mental health therapists, they have like 11,000, 12,000 people in their network, and they don't want any therapist's couch sitting empty. So they are matchmaking kids' needs to the therapist, agnostic of whatever their billing and their funding source is. So those are some of the things that are the vertical, as kids are moving up the triangle and having greater needs, things that we could fund to get them connected. Yes, did you have a question? Oh, okay. So the next question for you all. What are some activities or programs that your mental health board has been funding? Okay, what we're going to do is you tell us about a program that your mental health board has funded, and we'll try to guess whether we think it's a tier 1 intervention, a tier 2 intervention, a tier 3 intervention, a tier 4 intervention, and or if it's, you know, helping with some of the glue amongst these different ones. So, and at the same time, you'll get to hear about some of the things that your fellow mental health boards are funding. Okay, Deborah.
Team mental health first aid.
Teen mental health first aid. So this came up just a moment ago when we were talking about youth mental health first aid. It's a little bit confusing. Youth mental health first aid is a program for adults who are working with youth, and teen mental health first aid is a program for youth. And they're adults trained to help sponsor and develop their leadership around their mental health. So teen mental health first aid, hold up whether you think teen mental health first aid, based on what you've heard so far, would be a tier 1 intervention, tier 2, tier 3, or tier 4. Which one do you think it would be? Just hold up a finger. Okay, I see a lot of ones. Okay, I disagree. I mean, you could look at it as a tier 1, right? You could look at it as a tier 1, yes, in the back. Tier 2, yeah, I think so too. There were a couple of tier 2s, and the reason is not every kid's going to be in the teen mental health first aid. Now, some places are trying to conduct it with like a whole grade.
We're doing it with health. It's in all the health classes. So all the kids.
So everybody will get it. Okay, is it a particular grade that gets it?
We're just starting it, so it's just starting, but yes, it'll start with one particular grade, 9th grade first.
Mhm.
And hopefully growing it, but starting there.
Okay. So first of all, it's okay if you said tier 1. There's no real wrong answers, right? We're just trying to figure this out. It's a good intervention. It's evidence-based. Part of why I asked Deborah that question is that it's strategic, right? They're targeting 9th grade. So you think about kids who left 8th grade who are going into 9th grade. Everybody knows that 9th grade is a high-risk grade because they've just done that transition from a place where they were maybe had a sense of belonging and were familiar with everything. They're going into 9th grade and changing their friend groups, all those kinds of things. So it's a vulnerable grade. It's a wonderful grade to start a teen mental health first aid. And by the way I described it, it's like, oh, 9th grade, we have a tier 2 intervention because they're more vulnerable. You could consider it a tier 1 intervention because everybody in the 9th grade is getting it. I'm splitting hairs. Let's hear another intervention that you're, or another program that your community is funding. Yes, in the back.
Summer youth employment.
Ooh, summer youth employment. How does someone get into the summer youth employment program?
So there is an organization that fund several organizations for you to actually come and work in those organizations.
Okay.
So that they can have income over the summer, also do like internships. And instead of it being free labor, they actually.
Mhm. Nice. So can, rich kids get into it?
Kids. I'm not sure of that
Okay.
the income requirement, but there were not just only, underserved children.
Okay.
There were all different types, so we partnered with several different unique programs that, did a lot of other types of things, so.
Okay.
Several children got a chance.
If I'm thinking of the same thing that Chandra is talking about, there is a lot of input from the school districts about which children should be in, right?
Get sort
Are
of
we talking about the same
nominated or
thing?
something?
Yes.
Yeah.
So it sounds, what does it sound like to you? Tier 1, tier 2? I gotta see a tier 3. Oh, 1 or 2, okay. All right, so I was asking questions to try to help us ferret that out, right? So if it's truly available to everybody who wants to apply and the applications are all viewed just based on whatever their merit is, that would be considered a tier 1 program. If the programs that are nominating the kids are programs that are for at-risk youth, then it's probably a tier 2, right? One of the things that I want you to be on the lookout for are tier 2 programs, right? They are so cost effective if they work, right? Because they can get kids back into the larger triangle and prevent them from going into tier 3 or tier 4. All right, I want to take one more example. Ooh, I got a lot of hands. How about right back there?
We fund, activity at Big Brothers Big Sisters to, grow their match activity. To match a big with a little.
Oh, like a mentoring program, kind of? Okay, what do you guys think? Tier 1, 2? Okay, I'm seeing a lot of 2s. Let's take a few more and we'll just do them kind of quick. Other hands are up. Over here.
Administrative assistant also serves as a complex service plan. She worked with families and their thoughts and put them on the system at the same time.
So she's providing some like care coordination. And are these kids and families that are involved in the mental health system?
They're involved in multiple systems already. They're just trying to navigate all of those systems at the same time.
Okay, great. What do you guys think? 1, 2, 3, or 4? I'm thinking 3 or 4, right? Because these are multiply involved that most likely have a diagnosis already and are involved with multiple agencies. So probably close to the top of that triangle. Okay, who else? Yes.
Use self-regulation class,
Mhm.
so it's through, barbells and weightlifting for yoga classes.
Hmm. Okay, so it's a self-regulation class. Self-regulation class, what do you think? 1, 2, 3? We don't know a whole lot about this. Say a little bit
I can
more.
provide more, info, so it is to establish, social emotional learning. They also coordinate with the family to do wraparound services as well.
Hmm.
And so it is trauma informed. So
Who gets into it?
So I'm not exactly sure, but the trauma is target population.
Okay,
Youth,
so youth that we think might be more likely to have experienced trauma.
yes.
Okay, so what do we think? I'm hearing 2s and maybe a 3, right? It could be 3, but probably 2. Okay, you guys are awesome. So are you getting a sense of kind of the different levels? And as a mental health board, start thinking about like our RFP process, like is our RFP process set up to attract proposals for tier 1 or tier 2? Right?
I know
So
you're,
think about that.
I know you're done with examples, but I just want to go all the way back to
Go
the
ahead.
top of this. In Champaign County, we actually fund a lot of coordination in the birth to 6 space, and maybe you know Dr. Susan Fowler, that her research led to the beginning of the Birth to 6 Council, and then she's been a board member of ours since then. So there's been a very consistent long-term focus on
paying the agencies for the time that it takes for them to work together to reach all the children, it's really kind of great. It doesn't even need to.
It is really kind of great. I second that. So a lot of places don't want to fund the glue, the transition, the coordination, all those kinds of things. And we can write our RFPs to be more friendly to coordination. If all we want is the number of kids served, for example, or the number that got an intervention, if that's what we're looking for, we can kind of drive the kind of proposals we get by the way we write our RFPs. Does that make sense? So just think about whether or not your RFP process is friendly for these other kinds of interventions. Okay, so one thing that we really want to fund is this process of learning cycles. So when a intervention is employed, we plan it, we write the RFP for it, we've got what we want to do, then we go out and we do something, then we have to study it to figure out what just happened, you know, and then we have to adjust, we have to act. And these learning cycles, we don't want them to just happen once a year. We don't want the people to put in an RFP and then they wait until, you know, the next year to put in another RFP or another proposal before they reflect on what is happening. So in the communities that I'm working with, we are almost like doing this from one meeting to the next, like monthly. It's like we're going out, we all know what we're going to do, and then we see how it worked, and then we reflect on it and we adjust when we come back. Okay, so we are constantly in this cycle of learning about what's working, and with this public health model as our goal. So we're looking at, are we getting closer to our robust public health model? I will say that between plan and do, there's a lot of communicating that has to happen because the people at the meeting are not necessarily the people who are going to be doing the doing. So there needs to be like training, there needs to be communicating of the plan for people to do. And a lot of times that's just not something that people fund, right? Go ahead.
Is this more geared towards the, as you called it, developing the glue between the organizations, or is this meeting with a service provider monthly to evaluate, you know, do the planning, do the doing, the studying, and then doing a course correction?
What I'm recommending is that you ask your service providers to be doing these learning cycles. So if somebody comes to you and they say, we want to provide team mental health first aid in our 9th grade classes, that you're asking them to build in this process so that at every juncture they are learning about what's working or not working and making adjustments. Our RFPs usually ask people to just give us some sort of tally at the end, and we miss a lot of learning while we're just doing. So I'm encouraging you to think about how to build in this reflective process, and you could ask your funded programs to include a paragraph with their invoice every quarter that says, what have you learned so far about this, right? Tell us what you tried, what you're learning. It doesn't have to be a lot, but by doing something like that, you're essentially building in the expectation that this reflection in these learning cycles are happening. And particularly what we want to be doing is with each learning cycle, we need to be thinking about, okay, what about what we just did works? How does it work? For whom does it work and for whom does it not work? We have a lot of programs that only work for some people, and we don't necessarily build in the reflection around equity and in what context does it work. I want to say that part of what I want to talk about is how we absolutely have to have data and learning when we're implementing these things, and we're heading towards our 3 to 5 year and our 8 to 10 year vision, and being able to constantly evaluate, are we getting closer to are we getting closer to what our overall vision is? And so I have some opinions about the role of that for the larger mental health board, and then also the individual funded projects. And I want to sort of build in an appreciation for a data use culture where people are evaluating at every juncture how it's going. And I just want to mention a particular, I was working with an organization that did a survey that was kind of like a diversity, equity, and inclusion survey. They were looking at their climate, and they were pretty delighted that it came back that, 89% of the people said they felt like it was a safe working environment. And then I looked at their demographic data, and they had 11% individuals of color in their community, in their organization. Well, we didn't have that data disaggregated, so we didn't know for a fact that it was the 11% of people of color who also did not feel safe, but it was a bit telling. But if all we're looking at is 89% of the people feel good, that's a pretty good number, right? That's more than 80%. So I just want to raise that when we're thinking about our data, we really do want to be examining who's it working for, all right? What I'm recommending for mental health boards themselves is that they are monitoring their success towards this overall vision every year as they're moving along. So you start with your baseline needs assessment. Every mental health board does it. It's a snapshot of how effectively the current system's been meeting the needs of the communities. You've got these statistics illustrating the magnitude of the problem. You identify your strategic plan, and then you identify some changes that you'd like to make in that picture. Here's the part that I'm encouraging, and that is that you identify metrics that are associated with those changes that you guys want to see happen in your community, and identify ones that are collected routinely in your community and are sensitive to change. Okay, so for example, say that your community is really worried about suicide. You just don't want any of your kids killing themselves. So if you're moving towards a community that has no suicides, what are some of the kinds of data things that you might be able to access? Well, one, at a tier one, would be your Illinois Youth Survey data. Okay, so the schools ask kids, how many, in the last 12 months, did you think about killing yourself? In the last 12 months, did you have a plan? In the last 12 months, did you try to kill yourself? That data is there if your schools are participating in Illinois Youth Survey. The downside is it's 8th graders, 10th graders, and 12th graders. So it's not so sensitive to change, right? You could do a really great job for a year and you wouldn't be able to look at that to necessarily tell you. But it's a metric that's collected free. It's out there, it's available. Second thing you could do is get the numbers of your crisis team calls. Everybody has a publicly funded crisis team in your community that can tell you how many calls in a month, how many calls in a year are folks telling them that they're at risk of harming themselves. Now, this is a tricky one because we both want everybody who wants to kill themselves to call the crisis line, but we want those sum total numbers to go down over time, right? So we want everybody to call. We don't want any disincentives for people not to call, but eventually we want those numbers to go down. ER visits for psychiatric needs, hospitalizations for suicidal ideation, and then of course your coroner can provide you every year with the number of individuals who died by suicide. So as a mental health board, we identify the metrics that we are targeting, and we routinely take the responsibility for monitoring how our whole portfolio of projects are moving us towards that public health model.
So here's a problem that I've been stymied with, and that is what I call cross-pollination. So we have an effort, let's say out of our 708 board, But there are other influencers in surrounding communities that could conceivably be moving these metrics independent of anything that we did.
Yeah.
So we're kind of blind to, were we effective or not? We're just thinking, we're crossing our fingers, the metric sounds good, but we're just hoping that what we did actually is effective and not, in our area, it's the DuPage County Health Department.
Yeah.
Doing a wonderful job. So was us or was it them? And I don't think we'll ever know, but I don't know, do you have a comment about it?
I think you've got the completely right approach. Who cares, right? We're gonna do everything we can, and the health department's part of your team. The health department is part of your community system, your public health model. So I think that I want to hear what this person over here had his hand up.
Oh, yeah, so we've done a little bit of work in that area in our community, and also I am part of the American Evaluation Association, and they are wrestling with this issue as well, as they're looking at more and more people that are looking through the lens of trying to address complex adaptive systems and how do you actually know if they're influencing change. And a lot of what I guess would be an emerging best practice in that is setting up a peer community cohort so that you can measure change over comparable communities and your own community, knowing what are we doing uniquely different from peer communities. So it's not just looking at your trend line of are we improving, but it's looking at the slope of your line. Are we improving faster than a community? Or in some cases, everybody might be getting worse because of things like a pandemic that's completely outside of your control. And so you look at that and say, we're getting worse. What we're doing is not working. Well, maybe you're getting worse, but you're getting worse less than everyone else is getting worse. And that actually means you mitigate it. And another way that you can do that if you don't have comparable data to other communities is you can, if you have, you can set up peer neighborhood in your own region and compare neighborhood level data where you have a focused initiative versus where you don't, and see trend lines comparable. So those are a couple of the emerging best practice models. And we've kind of, it's not as always as easy as you want it to be because not every community also has the same data, but those are the ways people are doing that.
And it's expensive in many cases. One thing I want to mention though, because you're in DuPage County, right? Is that we have kind of a natural experiment going in DuPage County where we have, a handful of townships that have mental health boards and a handful that don't. And so one of the things that we'd like to see the health department do is disaggregate the data by zip code so that the townships can look at their data. Now, there's no wall right down the edge of the township. So, there's going to be bleed over of the good and the bad, right, between townships. But we do have kind of a built-in, because obviously we can't say to some part of our township, we're not going to give you the good program, because we just want to see if anybody in your school, deteriorates, right, relative to the program, and so we're not ever going to do a randomized control design in our townships. I mean, we just aren't. But we could do some things like what we're just talking about here, where we disaggregate our data by zip codes, and we can see if the communities that have mental health boards, which would be a great sales pitch, right, for those communities that don't. Now, there are other differences between the townships than just the fact that they have or don't have a mental health board. So we could never, there might be some thriving mental health coalition going on, even if they don't have a mental health board. And so we couldn't account for that. So yes, in the back.
Yeah, we're just on County Line Road in Cook County. Our main problem with zip codes is that they don't match the townships. Yes. We have 7 or 8 villages that we live a portion of it.
Yeah.
Community Memorial Foundation just came out with a data set, at least on Latino populations.
Okay.
And they have identified the townships by census tract. And so you can get that census. We just met with them a few weeks ago. Get that census tract. on a whole bunch of different data.
Yeah.
That's a lot better than zip code.
You know, you bring up the community health needs assessments are a great friend, right? They're a great ally. All the hospitals and health departments have to do these community health needs assessments. And so we can partner with them to try to get some of our data disaggregated because they're collecting it anyway, right?
That data is really broad. Pretty, it's statewide data or at best, county data. When you get to the microscopic area, there's hardly any data. It's
Okay.
projected.
Okay, thank you for saying that. In some communities that I've been in previously, it's not been that diffuse. So, you know, things like if there are 2 hospitals in your region, you can get things like how many kids went there for psychiatric reasons and, you know, how many kids were hospitalized for psychiatric reasons, stuff like that. That's quite, you know, granular. I think you'd be hard pressed to necessarily get the zip code of every kid, right? Because you're getting pretty close to de-identifying who the people are. But I do want to go to the last line here. Oh, it's not the last line, it's the last line on my notes. And that is that we can also, so as a mental health board, we're looking at how we're doing in our large portfolio. And then also in our individual funded projects, we want them to be looking at how they're doing towards that larger goal also, right? And so, for example, using the suicide example, we could have them just report that the number of youth receiving evidence-based suicide prevention programs. How many kids did Ending the Silence get to? How many kids did Signs of Suicide get to, right? How many kids actually got these prevention programs? And then a lot of communities will have a team of people do suicide screenings in the school, mass universal screenings. And so how many kids got screened? How many of those kids screened positive and needed some sort of follow-up and support? These are not terribly hard, very difficult data to get for an actual agency that's doing it. You're not going to know if you've got 4 agencies in town doing a similar project, right? You're not going to know if you're double counting kids. Like a kid could get a suicide screener at their doctor's office. They could get one at their school. They could get one in probation, right? So you can't necessarily know the exact number because you could have duplications. But these are some kinds of data that you might be able to get from your funded projects to carry you through. Okay, I think we're gonna do, yeah.
She brought it up, the screening for suicide in the schools, is there a standardized approach to do that? Versus having the youth serving organization, put together something and be asking their kids if they're having thoughts of suicide and didn't necessarily have a plan.
Sharon, we could probably do like a whole 3 hours just around screening. And if you guys want to do that, we could, because screening is a really hot topic right now. And depending on what kind of screening we're doing, but suicide screening, you like literally need to follow up in minutes. And I know there's a couple of school districts in DuPage County that do screening, and their last question is, I need to talk to somebody now about myself or a friend. And those kids don't go anywhere until somebody meets with them to talk with them about the intensity of their need or their concern. And then they also say, I need to talk to somebody in a few days, right? So they allow the kids to actually kind of triage themselves in the last 2 questions on the screener. But you know, there's developmental screening, there's social emotional learning screenings, there's screening for substance use, and a whole array of others. And obviously suicide is the most dicey one of all. So has your community identified some metrics in particular that you are trying to monitor?
Yes. Yeah. I'm in Hanover Township, which is a part of Cook County. And we have a very, very diverse township. A lot of, bilingual folks or folks that don't speak English. And so part of our strategic plan is just making sure access to service is available. And so we are monitoring and collecting data on different languages that services are available and what services are available in different languages. Just to make sure that we can kind of network and refer properly.
Nice. Okay, so your goal is a highly multilingual service array.
Yeah, or to ensure that everyone can have access.
Mhm.
Language should be fair.
That sounds great. Yeah, it sounds hard. And I'm thinking sort of the next iteration then is like, do the percentage of people being served in those agencies map on to your actual demographics? Are people accessing equitably? Yes.
A lot of board members that want way too much data.
Yeah.
Other thing. And really, what are we supposed to do with it? Like, I feel like it at this point has, like, if we could just have like simple matrix. But I feel like is no, we need to know everything, and it gets way too complicated. Like where we would need like a software system to try to even help us read them.
Such a good point, and I think that there's not a great appreciation for how costly the collection of data is. There are a lot of, like, for example, when somebody's going to get therapy, there's a bunch of questionnaires that have to be filled out, all this kind of stuff. And a lot of people want you to add something and ask them more stuff. And, particularly like say a child screens positive, right? And you're gonna try to get them support and you're talking to their parent. It's like, the parent just is, first of all, has to deal with the fact that they just found out that their kid is in such great need and they want their kid to get help. And then we're, and so in terms of costly money wise, but also costly in I know many times young people have gone who are on Medicaid have gone to seek counseling, and it could take 3 or 4 sessions for them to get through the IM cans. And after 1 or 2, the modal number of visits is 1, right? The modal number of visits is 1. Most people only go once, and they walk out and say, "Yeah, I tried counseling; it didn't work for me." So all I did was ask them a bunch of questions. Yes.
So flipping that around, are there standard metrics that a mental health board should reasonably be asking a service provider to provide? One that is, deemed not overbearing, but at the same time gets to the heart of, we want these agencies also to be performing. We want to be able to evaluate, is one doing better than the other so that we can direct our funds appropriately.
Yeah, it's a great question. And to be honest, I would really caution you on that idea that because different agencies serve different populations, and it's really often apples and oranges that you're actually measuring in the
Well, that's why I was looking for, is there something standardized?
Yeah.
That's reasonable, that's peer reviewed, whatever.
My colleague here would like to answer your question.
I'm so excited about this conversation. I think that one of the strengths of mental health boards that maybe we don't, maybe we can't always embrace this is that we belong to our communities. So the values of your community and what they're looking for from the mental health board might call for standards right there that don't apply in mine. We are sharing land with a gigantic research university, and that university tends to feed retirees onto our boards. So they want to know every single thing too. And so we actually, that's the flavor of Champaign County. It may not be the flavor at all of Vermilion, my dear neighbor and good friend. But one thing that we've learned to do, we're collecting more data than our staff can reasonably analyze or report on. But if we just put the raw data into a board packet, sometimes those research professors who have retired and are now on our board for something to do can actually really enjoy it and set us in a direction that they, so, but that's very specific to us. That might not be true in McLean or in your community either. So that, like, we've kind of been avoiding standards as an association, but I
How do we get better?
So, so I'd like to go back to a few slides before, to the learning cycles. Because the learning cycles are built into implementation, right? And, what you want is not to have people have your money for a year and then come back and say, we served, this minimal number of people, right? Well, if they're doing the learning cycles, they're gonna be figuring out why aren't people coming, right? And and who's it working for, who is it not working for, et cetera, and getting to that. So there's a real balance and there's a real trade-off in terms of the cost monetarily and sort of just bandwidth, right? To data collection. And so I'm making sort of two broad recommendations for how a mental health board would do, and then how individual grantees would do. There's another lady has an idea to.
Yeah, actually, it goes along with what you just said beautifully, because we went from a purely fee for service model, which was just counting widgets, to looking at implementing, and we are implementing the SAMHSA NOMS, the National Outcome Measure. Standards. So we're looking at NOMS, but as we're having that.
You would only do, right, if you were a SAMHSA funded project. Would you do the NOMS for fun?
Oh, we did the NOMS for fun.
You did.
Yeah, yeah, we do everything harder, right? People say do it smarter and not harder, and we do it harder.
You said it, I did not.
No, because we wanted a place to start. And what it has ended up being, though, is more of a hybrid, where we're looking at some of those national outcome measures, but we're also looking at, based on our community assessment, what did we see where the big needs were, and what are our agency's goals in participating with us. So one really good example of something that our community has been happy to see, which is kind of getting, we pulled it a little bit from the NOMS, but not surprisingly, we had huge wait times for psychiatry in our community mental health center. And it was, upwards of 6 months to see psychiatry. It was really, really bad. And so we sat down with them. We're like, this is a need in the community. We want to fund you $50,000 which isn't, going to solve the whole problem, but how do we do it? And then we looked at just pure, what is your wait time now? And they're down to, I think they're down to, or actually they have immediate openings. They have immediate openings now for psychiatry, because what they did was they built it out using nurse practitioners and all the other, and have reserved the psychiatrists for like the true psychiatry and not just the med management. And so that indicator right there, when our community sees that they went from 3 to 6 months wait time for psychiatry to, hey, there are immediate openings in psychiatry, that was big. And so it feels like, and it can't just be, unfortunately what it ends up is a whole bunch of apples, oranges, strawberries, pumpkins. And so you're not necessarily comparing apples to apples, but the community, when they see that input, and they're the ones who, it's their tax dollars. They're saying, these are what matter. These are the things that matter to us. These are our priorities. And that's how we're measuring it with our agencies. So, it's not a standard model, but we did use NOMS as the jumping off point for what are the questions we want to ask.
Interesting. There's one gentleman over here, and then I want to go through a certain number of slides before we take a break. Just so you know, haven't forgotten that we all have bodies. And we are human beings.
I'll be brief. Data is important, but data doesn't tell you everything.
That's right.
We've got mental health first aid training, both the youth and the adult training for the last 8 years in our county. The suicide rate is stayed about level, unfortunately. But I can point to dozens of people in our community who are still alive. because they came in contact with somebody who's been trained. Those numbers never show up anywhere, these statistics.
Yep.
So the data is important, but it doesn't tell the whole picture. And we need to make sure we don't leave out the part of the picture that the data doesn't include.
Thank you for that. So I'm going to talk a little bit about nuts and bolts of community coalitions. So just to be transparent, I facilitate community coalitions in a lot of different places, right? So I'm going to try to capture what are some of the tips around community coalitions. But the reason that you might want to have a community coalition is to essentially lay out to all of your stakeholders this goal of this fully functioning, vital public health model, and then engage all those partners in making that happen. And that's what we're doing in these community coalitions. So this is a pretty dense slide. I have $3 signs at the top because these meetings are essentially costly because everybody who's coming is not doing whatever else they were going to be doing. So we have to think about how to get the biggest bang for the buck when we bring people together. And you need to have somebody who's leading it. Okay, it's perfectly fine if you have a person who's in your office. It would be perfectly fine for a mental health board to have an employee who does this work. You could hire somebody who does it like me, or you could find one of your agencies that wants to take on this kind of a leadership role. The first thing that I want to say, and I feel is really, really important, is that you need to, let me say, one of the reasons why it's worth putting your money into it is because they can bring you collaborative and well-informed proposals. Every year, your coalition can essentially bring to you and say to the mental health board, we know what we need. Like we've adjusted, we're working together, and we've found some holes. We no longer are duplicating. We've got this seamless system, and here's the thing that we've identified that we need. And we think this agency over here is the best one to spearhead it. And when they write letters of support, they really mean it, because they've identified not only the service or the as well as the provider. So I think that is super valuable to mental health boards, because you want to fund everything you get, right? So to have proposals that are really, really specific to your community's needs. Okay, so first thing I was going to say is match your invitees to the agenda of the meeting. A lot of people have the misconception that having more people at the meeting is better, and it's just not true. You want to have the right people for the agenda, okay? So if you think about it, if you have a room full of superintendents, you're going to get different work done than if you have one superintendent, one PTO person, one social worker, one person from the YWCA, right? It's like, what is the right agenda for that group, right? There are agendas that are right for that group, but it's not the same agenda that the work that you're gonna do when you have people who are all superintendents in the room. So I'll talk a little bit more about that later. But I think this is a big mistake that a lot of coalitions make, and the meetings turn into everybody just reporting stuff out as opposed to an actual working meeting. And remember, these are costly. So secondly, if you can, do a virtual meeting, and whenever possible, record it, because you don't want to have to pay people to travel, right? And you're going to get more people on, and you'll be able to meet more frequently, right? Quarterly meetings is too long of a time if you're actually doing these learning cycles, right? Limit the time you spend on introductions. Now there's a time and a place, there's controversial thing here, but if you've got like under 5 people in the room, fine, everybody introduce themselves, but you probably already know each other. If you got a big group of people, have people rename themselves in the Zoom, tell what agency they're with. You want to avoid the show and tell. at all costs, right? You've all been on these meetings where it's like, I'm Brenda Huber, I work at the health department. At the health department, we do 8,000 things, and I want to tell you all about them, right? By the time everybody gets done introducing themselves, you have no time left to work. And so there is a time and a place if you have a new group of people and you want everybody to say their name and tell their favorite Thanksgiving dish or whatever, some sort of icebreaker thing is kind of nice to get people to know each other, but do not spend your meeting time doing that. It's just too costly to you as a community to spend all your time, or a big chunk of your time on that. I've taken to creating what's called a Padlet. It's just basically an electronic bulletin board. I have everybody who routinely comes to the meeting have a picture of themselves and a little bio. So be like, oh, who was that again? Oh, look at the thing. And I was like, oh yeah, that's my, she works over at the such and such, right? And have all that stuff available for people electronically. Keep rolling notes in a shared medium. By that I mean every meeting, you just start typing the top of the page. Here's our agenda, here's our notes for this day, and the last meeting is right underneath it, and the meeting before that, and we can go back and check things. We have continuity. People can't come to the meeting, they can just go look at the notes. I invite folks even during the meeting, they can add announcements or put their name in the attendance or whatever, and make all that available in an online format. Keep the time for announcements also to a minimum. So set aside a time to say, this is the time we're going to do announcements, or have people plunk them into the shared drive so that you spend the actual meeting time tapping the expertise of the group, doing your plan, do, study, act, right? So people are going to leave the meeting with an intention of what it is they're going to do, even if it's just they're going to think about it, right? But they're going to leave the meeting with an intention of what they're going to do and an idea of what success at that thing would look like. And then they're going to come back to the meeting and we're going to study. We're going to study what happened. We're going to reflect on it and get ready to act. So, and the last thing I'll say, and I learned this in Livingston County, we need in-person celebrations of our progress. So when I was working in Livingston County, every year we would have what we call the summit. Everybody who touched children's mental health in any way, shape, or form was invited so that we could celebrate our progress and the things that we learned and are learning. And I would highly recommend that mental health boards put some money into that. I've been in, the meetings where people are pitching their proposal for the next year. It's like so inspiring, to hear like, oh, how many people got, services through the domestic violence shelter and how their lives were changed and all this. And I'm hearing that because they're asking for money for the next year, as opposed to, getting together and celebrating what the mental health board has done and let people know in the community what the mental health board has funded. These are just a list of the kinds of people that you might invite to be part of a community coalition involved in cross-sector work. And I'm sure there are some things that aren't up there, but I wanted to highlight specifically, obviously anybody who's ever applied for funding from you, I would invite to your coalition, but I want to highlight specifically education and medical. So it's very hard to get education folks to your community coalition because you're meeting while they're taking care of the kids. And so what I have seen successful, the same is also true in the medical field. It's very hard to get a representative from the healthcare profession to be part of your coalition. And so the thing that I've seen that is successful is if your education sector or your medical sector will designate a person that will liaise for them. So in other words, somebody from the regional office of education or somebody from the special education co-op comes, and then part of their job is to represent everybody else and then to take information back to the education sector and liaise. And the same thing goes for medical. In the medical profession, in the medical field, it could be whoever is the lead person for the community health needs assessment, right? They could be sort of the designated person to run back and forth, or an insurance care coordinator or something like that. If you can get your healthcare sector to agree on something like that. Most places have multiple healthcare systems. And so it's dependent upon how agreeable those systems are to collaborate. Parents and cultural brokers, and those are the last two sections I'm going to cover. So parent engagement, very, very important thing. When you say parents, who do you mean? Well, there are lots of different groups of parents. There are professionals like ourselves who are in the meeting, who are also parents, who often will say, yeah, I couldn't get my kid counseling. We had to wait 6 months, right? So you can have the voice of professionals who are also parents. You've got parents who are actually already employed in peer support roles, like family resource developers, wonderful creation in the suicide assessment programs, the mobile crisis response programs that we have around the state. There's always a parent who has gone through the system, who is paid to help other parents go through the system. You have parents who are just part of volunteer parent-led organizations like the PTO or NAMI. You have parents who are currently, who at one time had a child with mental health needs that are like, I got to give back to this system, right? You've got parents who are currently consumers or parents of kids with mental health needs. So these are just some examples of different parent stakeholder groups, if you will, that have something to offer to a group like this. I put dollar signs up there because unless the parents are there in a paid role, we need to pay them to participate. And this can be costly to pay parents to participate. And so in one of the coalitions that I'm working on, what we've really done is every agency in the room has gone back to their agency and try to cultivate elevating parent voice in their agency. And then they're the conduit back to our coalition. But it's difficult to capture parent voice, and it's so critical. It's so critical. These are, and we talked about it earlier, youth, capture youth voice. It's like, these are the people who are benefiting from our efforts, and we need to know what they're thinking and feeling. I recommend that we organize parents into a hierarchy that mimics the hierarchy in all of the other groups. So hearkening back to that comment about having the right people at the table. So if you think about how a school is structured, you've got your superintendents, your principals, your school support personnel, your teachers, you've got this hierarchy. And when you have meetings, and you're trying to work and implement something new, you want to have, you might want a bunch of teachers there, right? It's rare that you're going to do the same work in a meeting with all of those people, although it's in a coalition. And so what I'm saying about with parents is like, okay, you're going to have parents who are representing groups of parents who are not going to come to your meeting, right? So to organize, these are parents who represent these parents and have a somewhat of a hierarchy, so that if you are having the CEO of the health department and the superintendent of the ROE and whatnot, you have a parent who is at that level in the parent organization, right? And if you've got people who are the actual clinicians, you have parents who are the right parents to be in that meeting. Does this make sense to you? I feel like I'm having a hard time explaining it. But a lot of people have this idea like, oh, we're going to engage some parent volunteers or some parents, and we're going to have these 8 parents, and we're going to have their opinions, and we're going to, they have to come to all the meetings. Right. Well, what organization do you do that? Where it's like, oh, we're sending all of our social workers from the schools to the coalition for the mental health project. Do you understand what I'm saying? So we organize our parents so that people are represented, and then the parents are just like the person at the ROE is taking information back to the groups of parents that they represent. Yeah, go ahead. Maybe you can help me out.
So, and I'm trying to clarify this in my mind as well. So if you have, say, a social service agency that does developmental disabilities,
Mm-hmm.
you would ask them to elect a parent or two from their age that gets care for
Yeah.
their child
You could.
through their agency. And they would represent the appearance of developmental disabilities.
Yes, and you could end up with parents who represent a dozen different agencies, and they would have a whole group of parents. Do you need to have all those 12 people then come to every meeting? Or could somebody of those 12 represent them on a coalition?
Okay,
Does
so
that make
you're
sense?
saying the agencies, I'm just
Yeah.
asking, developmental disabilities agencies. They pick a person, a parent
Mhm.
that's willing to, you know, to have the time for the coalition, because we know how hard that is.
Yeah.
And then they have a meeting, and then they send a representative out of that group.
That's one way that you could do it. Or you could have the parent representatives from all the different agencies that are on the thing, have a whole group of parents that represent all of those different stakeholder groups of parents.
Right.
So you could do it however you want. I'm just trying to dispel this idea that we're gonna, pick 5 parents, they're gonna represent all the parents in our community, and then they've all gotta come to the coalition every time,
Just one can, and they can
Yeah.
disseminate the information.
So almost done here for our break. The primary purpose, I just want to really highlight this, that we want to absolutely avoid us versus them dynamics, which can emerge when we're trying to engage parents. A primary purpose of parent engagement is to provide feedback on how the system operates and advocate for improvements. But what happens a lot of times is it's one directional, right? The parents are saying, we don't like how you're doing X, Y, and Z, and are giving constructive feedback. Well, the clinical team doesn't say, well, we don't like how you're not doing such and such, right? It's a one directional thing, and it's often public. We have meetings where people are sharing their opinions openly. This is a very vulnerable situation for both parties. Your mental health folks, they are doing their best. They're putting their blood, sweat, and tears into their work because they care about it. It's not because they're getting paid so much. And it's very hard to sit in a room with people who tell them that it's not good enough, right? And by the same token, it's very hard to be the person who's saying what you're doing isn't good enough, right? And risk being rejected or attacked. And so we need to provide safe mechanisms for parents to provide their feedback and for the professionals to receive the feedback. We want to structure our meetings to be parent friendly. So avoiding like a lot of, I've heard parents say, yeah, I just Google everything I don't understand in the meeting. Like, what's that acronym mean, right? We want to have meetings that are parent friendly so that parents have a very true sense that they belong at the table. SAMHSA uses a 25% rule of thumb. Just consider it. What they're going for there is that you want a critical mass of parents in a room so that they're not, isolated and so vulnerable. And then you might even want to hold pre-meetings and post-meetings. And this could go to what we were talking about earlier, where there's a meeting beforehand so that the parents know what to expect in the meeting, and then a debriefing afterwards. A lot of places do that. But we want to build a culture of collaboration where we're all an us and we're joining together around the purpose of children's well-being, and not oftentimes there's a sense of, the parents have to go in together to fight for their child, to fight the system. And that is not a productive way to engage parents. So professionals need to be prepared and trained to know how to engage parents in that plan, do, study, act process. And parents need to be prepared for their roles also, for participating in those cross-sector meetings, but also in communicating to the parents that they represent. And the last thing before we break is engaging cultural brokers. So systems are designed by, for, and about members of the majority culture. So white people, and this is just how it works, because everything is designed around the majority because it's an economy of scale. So our systems are generally by, for, and about members of the majority culture. And I did not make up this question, but I heard it in a community I was working with. A consultant said to them, ask yourself this very revealing question. If we didn't want population X to participate, to belong, to benefit, what would we do?
Wow.
And it was so revealing because they actually identified practices that they were engaging in. You know, you have the meeting at a certain time, you know, it's only in English, you know, I don't know. But they identified a number of things, much to their chagrin. I also want to encourage you to consider folks who are extreme minorities. In other words, if you are the one Black kid in this rural school, you're a minority, but you're an extreme minority. And I call it the wind chill factor or the heat index. It's like, yeah, it's only 32 degrees, but it feels like 20 below. And so to think about that when you're thinking about cultural brokers and designing a system for what is, you know, the outlier in that community. Who are cultural brokers? These are people who have a deep understanding or lived experience with a cultural group that you're wanting to serve, and also have an understanding and appreciation for the service system. And they can kind of interpret back and forth. They're individuals who are trusted within the community, who can help members of a culture overcome stigma with a warm handoff. They can provide input to make the system more sensitive and responsive to the underserved culture. Now, I want to caution, don't expect your parents to also wear this additional hat unless you're being explicit about it. Because anybody who's a person of color who's also a therapist knows that many times you're not just wearing the hat of the therapist, but you're also wearing the hat of the culture of people of color at the same time. And so unless we're being explicit about it and we're compensating people for it, if you want to have a cultural broker in the room, pay somebody to be that cultural broker, as opposed to expecting the parent to do double duty if they happen to represent that cultural group as well. One thing I want to say about paying people to participate in the coalitions, we have to do it. We have to do it because they're bringing their expertise. It's not just that we want them there, we want to honor their expertise. And we also have to recognize that as soon as we start paying people, there's another relationship that happens, right? So just to be aware of it, that there are two relationships then. If the person's there to represent parents, and they're also there to do a job for you and to be evaluated and get paid, etc. I wanted to give an example of a cultural broker. There was a very, very conservative religion in this rural area. And there was a mid-level provider, a nurse practitioner in the doctor's office who was a member of that religion, which was almost unheard of, frankly. But she was in there and we were doing universal screening in this doctor's office. And she would say, oh, I want you to see my counselor when somebody was screened positive. And just the use of the word my, people would go to the counselor. And she'd say, I want you to see my counselor. This person's a part of our us. That's an example of being a cultural broker and opening the door. A lot of the communities that are having a large influx of different refugee groups and so on, there are faith leaders for these communities and natural partners that we can engage with. In one community, the mental health board specifically trained all of the pastors of all of the different denominations in youth mental health first aid, so that they had a sense of not only where to go for help, but also how to support people who are adjusting to this culture in overcoming any stigma that they might have. Okay, we have got to take a break. So let's do that and we'll come back, what, 10 minutes, 15 minutes? 15, Deborah says. Okay, we'll see you in 15 minutes. You guys are awesome. Thank you so much for participating.
Can we unplug it and try to plug it back in?
Okay.
Yeah. Is it working now?
There, it worked. Good job, Jody.
Sorry about that.
No problem.
And the folks, I just told them to, you know, chat or put a hand up, raise a hand if they have questions, if that's okay.
Yeah. All right. That was fun to meet a few of you. I wanted to share, one of the participants, reminded me of something that I, wanted to say when we were talking about cultural brokers. And, when we think about being in these coalitions, one of the things that, I think we all need to do, even like in this room right now, is to, think about who are the missing voices. So in the Plan, Study, Do Act, I had encouraged you to ask, like, who's it working for, who's it not working for, and so on. But we can simply look around the room in our coalition and say, whose voice is missing here? And then really go about building relationships with those communities that aren't represented in our group. And understand how those cultures and communities identify and want to be seen and included in the work. I want to go next to maximizing our community assets. And this section is probably the most boring part, I think. But I have a few just kind of tips. One is that starting up something new is hard for an agency to do because especially if you're going to get Medicaid funding or something like that, it's a long time before you see money. So one of the things that's nice is that a mental health board can pay to start up something, to get something launched. So if it's something that your coalitions identify that you really need in the community, putting that money up front can be really, really valuable. And when you are launching a program, one thing that you might want to ask is, does the agency have the existing personnel to do the launch? Unfortunately, with our workforce shortages, there are a number of agencies that have a great idea, but then it's super hard because they have to hire someone
In a good case scenario, that's 3 months. And then it takes you a good 3 months to onboard them, for them to really understand their role and all that kind of thing. That takes you to 6 months. And in most communities, that's when you got to put in your proposal for the next year. So they're putting in their proposal without actually really knowing whether whether the project is going to, like what kind of data are they going to have, to put in for a next year of funding. So it's advantageous to fund programs where an agency feels like they have the personnel to at least launch what it is that they're wanting to do because of the workforce component. Another thing that can be really advantageous is to fund trainee programs. So if you have a community mental health center or other agencies in the community that can partner and be like an official training site for practicum, for internship, etc., for educators or mental health providers in your community, you can fund supervisors for them so that they're giving these students really high quality training. There's also workforce shortages in higher ed and to train these folks. And so you can become an official part of the training pipeline. And you can, some communities will fund stipends for those students. Some will fund tuition waivers, those kinds of things. So those are some things to think about. It is a risk if you put a lot of money into one person. So I sort of encourage putting the money into a pipeline, into the structure to train them. Another thing is program development. If in a sense, part of what the coalitions are doing is putting their heads together to develop the programs that are needed. And so to have to pay for the actual work of developing the program. Another thing is to keep in mind that systems change takes at least 3 to 5 years. And most all of you have a year cycle. You only fund a program for a year. And so to have some way, some form of transparency that you may, that people are maybe asking for a portion of a program, like this is what we're going to do this year, and just have that be a transparent thing. Clearly you can't make any promises from year to year, but if you can say something to the effect of that, if they're meeting these sorts of benchmarks or whatever, the odds are good that they'd be funded again or something like that, because change just takes time. And it's very hard to produce a lot of convincing data about change in a single year. And then the last thing I just wanted to mention is about non-residents, especially in schools. This is hard. And I think one of you were talking about the zip codes and all that, it's confusing. And so I just like to encourage mental health boards. Obviously, you want your money to be spent. You need to have your money to be spent on your residents, kids that live in your community. And if some other kids get some goodness along the way, it's only going to benefit the kid in your community even more. If we're doing a classroom-based intervention and only half the kids in there are from your township, the fact that the other half are also getting the intervention is only going to help your half. And just to the extent that it's possible to have an open mind about that. Next thing I want to talk about is natural settings. So natural settings are the ideal place for us to embed, obviously the tier 1, but also tier 2, even tier 3 services if we can. And some examples that have been really successful are those classroom-wide interventions, after school interventions, integrated behavioral health in primary care. In other words, putting behavioral health people right in primary care practices. When we did that in rural communities, it was amazing. The suicide rate of men in rural areas is really high. And we put behavioral health providers in primary care, and they went into the visit with the provider as a matter of course. And the number of people who would have never, ever, ever let them be in the same room with a mental health provider, that we were able to help was really astronomical, especially in a culture that's very, I don't know, the word that's coming to my mind is like, macho, masculine, you know, the males in that rural area just really, really took to getting help in that way.
What we also found is that somebody, you going into the office, they didn't know you were going to see a counselor. They just thought your neighbor might think you're just going to see the doctor. So there was no stigma.
Exactly. Thank you. School embedded therapists are all the rage right now. There are lots and lots of school embedded therapists. One of the things that a community I'm working with right now is doing is building a protocol for how efficiently and effectively to use embedded therapists. When I started to work with them, there were many schools that had 3 different providers coming in at any, in a week, right? And so that's 3 times the work for the school to navigate administratively getting kids connected with 3 different therapists from 3 different places. There's the bandwidth involved of, hey, we've got a kid we think needs therapy. Who's the one who calls the parent? How do we get the signature that says it's okay to talk to these people over here about your kid, et cetera, et cetera. So there's a lot of work that goes into making a school-based embedded therapist actually really helpful. And so they're working on building these protocols so that all across the county, people know, like, what are the questions you should ask when you're thinking about doing this, and how to set it up in such a way that you don't end up having your school social worker just doing a bunch of case management to get kids connected to a therapist from the outside when they could have just provided that service themselves. Social workers in police departments, that's been all the rage in Bloomingdale Township, and really, really, really helpful. It's similar to like with the doctor's office, because the mental health provider will go out on the call with the police and then make a connection and follow up and support a family until they're stable. And then social workers in the juvenile court. That was one of the really innovative things that the presiding judge in Livingston County did, was she made it mandatory as part of the pretrial paperwork when a youth was considered innocent. She had them meet with a social worker and be screened. And we found this whole population of kids that were falling through the cracks. And this was how we found them and gave them mental health support. I was under the impression that they would be kids that had sort of gotten lots and lots of services that didn't work. For some reason, I had that in my head, these are kids that, are just resistant to help and intervention or whatever. I was so wrong. These were kids, the first year, almost 20% of those kids ended up in the welfare system, in the child welfare system, because they were actually living in really, really bad situations. And that was sort of their positive screen to get more help. This is maybe more granular than I need to be, but one of the things that I've seen is that sometimes you have agencies who have a really, really great thing that they're the only one that offers. And instead of doing that thing that they're the only one that offers, they do a whole bunch of other things that other people are also doing. And so they can provide less of that one thing that everybody needs. So part of what we do in these coalitions is figure out how to use our resources really, really well. So an example I have is the YWCA Metropolitan Chicago has a home visiting program for 0 to 17-year-olds. So once a week, you could have a home visitor to come and work with you and your 12-year-old on attachment and evidence-based systems work. Nobody else does that. It's really, really precious. And I was working with a school district that was going to hire this program to work with them. And then the sort of contract was evolving, and they're like, oh, and you can do webinars for parents and all this kind of stuff. I was like, no, no, just do the thing. Just do the thing that nobody else can do. You're the only one that has this program. Let's like max the heck out of it. Let's do it as much as we can. We've got 4 agencies over here that do awesome webinars for parents. Let's let them do their thing that they do really well, right? And so this is just sort of like something that has emerged for me in some of these coalitions. We don't end up doing that, right? Because we're using all of our resources really strategically. Another example was a community that had these social workers in the police department that are literally on call 24/7 all the time. And they go out on all these calls and everything, so much so that they can't participate in the meetings. You know, they can't come to the coalition, right? Because they never know when they're going to be called out and so on. And huge success, making a huge difference with families. And then that same police department said, we want to put a therapist in the library. And I was like, but why? Right? Because we have all these other agencies that can easily put a therapist in the library. We are not going to take this great thing that's happening. You're the only people doing it, it's the police department. We're not going to take your therapists and put them in the library and then not have them available to go out on these calls and stuff. So just thinking very strategically about, because everybody has great ideas and we all want to help people. But one of the things that can come out of the coalition is thinking about, and that was not a youth focused proposal, so it wasn't even something that I had anything to do with. So the exceptions would be, I guess, if you have, you're a very rural area and you kind of only have one place, right? If you only have one mental health center, then they kind of have to do everything. But when you have more than that, it's like, let people do the thing that they really shine at and then coordinate across them. The other thing was if one service is an on-ramp to another, like we were talking about the natural settings. So I'm working with a school that has a program where they are doing webinars for parents. And the particular company that they're using that has the webinars for parents offers one-on-one coaching for parents. They get a half-hour coaching for any student going to their school. They can get half-hour coaching a week with texting with their coach in between and a whole bunch of other services. And the webinars sell the coaching program. And so we've got really good utilization already with that new program. I'm not going to spend very much time on this next slide, but I want to say huge, important things are happening with Medicaid in schools, and the schools don't even know. They don't even know about it because HFS and ISB, neither one is taking the lead to get this word out. So something that you all need to know is that your superintendents, your school board official or school business officials, if they haven't already, need to understand expanded Medicaid. So we have a Medicaid system in the state that all of you know your community mental health center uses and so on. Healthcare settings use them. It's complicated. There are HMOs, there are MCOs, there are different payer rates and all that kind of thing. But generally speaking, in the state of Illinois, we have pretty good reimbursement rates for what our mental health centers get for Medicaid. It's been recently raised. What's going to go on in the schools is completely different. So as of April of this year, schools in Illinois can get money for every health service that they provide to a general education student that is on Medicaid. So for schools that have 80% Medicaid enrollment, this is huge. This is huge. And for large school districts, it's huge. There's a process where the school will do the same kind of thing, like filling out claims for individual students, but that's not really the important part. The important part is for the school to enter in all of the charges that they have spent on health services, because then that goes into a formula based on how many kids at that school are Medicaid enrolled, and the school gets that money in a lump. The first schools that are really in the know are going to get their first lump in June. the ones that are ahead of the game. I would say, sorry, my son has type 1 diabetes, and I track his blood sugar, and my phone is alerting me that it needs attention. He is 18, he will attend to it, but that's what that was. I don't want to go on and on about Medicaid expansion, but it's super, super important, because if schools do it wrong and they're not in the know, they could end up having to give money back. So this is really, really important, and there's some experts in the field that can help if you want to do something like have a professional learning community of, you know, your schools in your region or something like that. I'd be happy to connect you with somebody who can help you. All right, we're getting close to the end. So what I would like you to do, we have just to talk about workforce issues and a conclusion. So what I'd like you to do is to think about what's one thing that you thought of today that you'd like your mental health board to fund. And it doesn't even have to be that specific, okay? Just one thing that you're taking with you today that has come to mind as we've been talking about all these possible things on the buffet that your community could do for your kids. And I'm not going to do parent share because you guys are so good at participating. I mean, if there's anybody in the room who hasn't spoken today, now's your chance to share your thoughts, because I actually was telling this gentleman over here, I went to the store to buy these Post-its on purpose because a lot of people don't participate. And I thought they can write it down on their Post-it, and they might be more likely to participate if they, you know, they've written it down on their Post-it. And then I'll collect the Post-its and I'll put this all together after the session. I've not used the Post-its, so I'm going to take those Post-its home. So think about this. What, as of right now in the buffet, what's on your mind about something that you thought of that you'd like your mental health board to fund, or some other practice that you're taking away?
Since you were talking to me about these, I'll bring it up. I don't have a specific program, but I would definitely like to see us pursue something that would address tier 1 needs. I'm an engineer by background, and what I've learned is it costs 10 times as much money to fix things every step past where you find it. So fix it at the beginning, or at least improve upon it at the beginning. It's going to save a lot more money in the long run, as well as the mental health.
I'm so glad we're recording that. We are, aren't we? Because that's exactly the point of the public health model. So thank you for saying that. And for those in the back who's saying, it's like, for every dollar we spend on this tier 1 work, and we prevent actual difficulties from arising, we've saved, not just financially, but in human suffering. Yeah, who else had their hand up? Yeah.
I'm from the Schaumburg Mental Health Board, and we're new. Personally, what I don't know right now, Bart sees what I do, I admit that. But this business of paying an agency to launch a program in our township that currently is not here brings up a question. Is that something that we can legally do if they're not currently providing any kind of billable services? Can we fund them to try to get their foot?
You're probably asking the wrong person, because I'm thinking, yeah. I mean, I don't know why you couldn't.
I would think if it's a service that meets the needs of mental health, substance use.
Well, absolutely does.
Yeah.
I mean, as long as you feel the agency is reputable.
I do.
Yeah,
But
and
currently they cannot, document that they're serving anyone in the community.
I see. So it would be helping an agency come into the Schaumburg area. I think that would be amazing, and I don't know why you couldn't fund a program like that. And when you think about how you write your RFPs, right? If you write your RFPs so that they have to have a demonstrated history in your community in order to be considered, right? I don't think there's anything in the law that would say that. The other thing I would encourage you to do is to have your existing providers come together around, what it would be like to have this new service and how it would fit with the service array that's already there. Does that make sense?
We don't really, we haven't funded anybody yet, but the providers in our area that do provide the services we're talking about aren't doing a very good job.
Mm,
But there's an agency that's sort of almost next door that does an outstanding.
very good. Interesting. Well, I would, again, I would encourage, because those people that are already there aren't going anywhere, right? And so, you would want them to be part of the fabric, right? You would want the, people that you're inviting to come in to be able to play in the sandbox with everybody who's already there. Does that make sense? Yeah, I think it'll be a bigger bang for your buck if they're all paddling in the same direction.
We can fund fee for service. programs.
Right.
We can also fund grant.
Mm,
Grant money, this is gonna start up a service that may turn to fee for service later.
yeah,
But the front end money can be grant based on this is what you're doing with it, and this is the establishment of the program.
Even though they're not serving many
Even though
residents of our township currently.
As long as they're headed towards setting that program for your residents.
I mean, our board of directors is people that have been more adamant about providing or funding local agencies. But if this agency is wanting to come in and expand in the county, then that's different. But again, is it gonna make some conflict with the present providers?
Yeah, that's one thing with we have funding guidelines, and probably most of us have written documentations that have funding guidelines, and that's one of the things that we address there. Usually it's Madison County residents and Madison County providers. However, if that service isn't there, doesn't exist, we can bring in other providers to do that service, so. Kind of our,
somebody in the back?
So this is back to your question.
Uh-huh.
Okay.
Yeah.
So I would really like your suggestion on like that, I don't know, you use like that community, the school, like resource card, guide, like they know everything is easy. That is being a huge challenge. I really like that, like funding something to pay for that.
Are you talking about the embedding, the protocol for embedding therapists? I'm not sure what you're saying.
So how, like, for a school, you said like a resource guide, or like this is
Oh.
all of the resources in this. And then kind of like that menu, so I really like that, and then also very specifically is like, we're talking about like these interventions, like they share, so I have an 11-year-old that is on the spectrum, actually I have 2 on the spectrum, but I'll just stick to my 11-year-old. So I have an 11-year-old that's on the spectrum, and so when he was in preschool, kindergarten, he got like tier 2 or 3, services, interventions, and now he's in 5th grade. And so like, I know like the money is important, but then like when you see, so like now, so he hasn't had an IEP since kindergarten. He has a 504. If you guys know what that is, just so, hey, this is what's coming your way. But he's doing so well. He has so many friends. He tries to like have social engagement. So take like candy that he doesn't like to school. So that yeah, so then the kids will be like, hey, he has tons of like different friends. This morning I dropped him off and we had our dog and kids were like, and he loves it. And so he's like academically he's doing well. He's still challenging, he still has his moments. We still have to do lots of things. He's like in a social group right now for other kids with autism, just to keep that increasing that skill set. And even like his teachers are like, if you didn't tell us he has autism, we wouldn't know.
Yeah.
Which is not always the case at home. However, but like, so I just want us to also, all of this is extremely important, but I also just want us to remember, like, there's people, like, as a mom of 2 kids with autism, and my 6th graders are doing really well. Neither of them have missed a day of school this year. And that has been like tons and tons and tons of interventions and work. And so I just want us to remember, like, and I know there's other parents in here with the same situation, but like, we're talking about people and how that has improved our family life. And
So this is a testimonial for early intervention. Sharon?
To piggyback on that, I'm wondering if anybody is working with your regional group of 5 group. And how you are working with them at this point. It's fairly new. And the region that I'm in, you know, they conduct their needs assessment and kind of, you know, what are we gonna invest in next? So I'd like to see, you know, our board kind of figure out how we can work in some way.
We're working with our Birth to 5, actually had a listening session yesterday with all of our providers, and ours is really about workforce development, and I've shared some about that, and we'll talk about it tomorrow, but we're looking at developing a paraprofessional certification, but that's one of their strategic goals, and so they were so excited to hear about the possibilities of what this training and education and this other level of workforce that could be available to provide parent and child support and skill development for parents. I mean, that's really where it really hones in on is if it's smaller children, it's more parenting skills than the child issue. And so that's kind of what our introduction, we've just met like 3 times, so it's infant stages, but already some good discussions out of that.
So that's, it's kind of akin to prevention programming as well. We've tended to, I guess, focus more on, I mean, we're doing prevention programming, but you know, it's really tied to mental health, first aid, youth mental health first aid, or substance use prevention programming versus teaching basic skills that aren't, you know, on the face of it necessarily tied directly
Or
to mental health.
development.
I mean, you can make the connection, but if it isn't expressly mental health, just curious how we kind of get around that.
So for us, I'm on their email list to get their updates on that, but we already had it from early childhood collaboration, please. So we actually are funding the social and emotional screening, the collaboration, and then also the expansion of training to be able to do those screenings. So that way they go into those or to connect with individuals with the daycare with different locations and train their staff to be able to provide social emotional preferred to time.
So I'm gonna put a pin in this because I think these are great discussions and I hope you'll carry them on through the evening at dinner. I want to wrap up my piece so that we can conclude on time. So the next item I had was to talk about workforce strategies, and I'm going to have to move up here to the podium, it looks like. Actually, would you do that for me, Jody, in advance? Thank you so much. So I'm not going to go too much into this slide, but I'll just capture the gist of it, is that one of the things that we are doing is we're asking every human to take one step up in their level of responsibility for children's well-being, even kids themselves. We're asking them to take on additional responsibility to support themselves and their peers. And so, so if you think about our multi-tiered model, we might have peers providing a tier 1.5 to their peers, or teachers providing tier 1.5. So something in addition to the universal classroom and so on, because the need is so great, right? So all of us are taking one step up. And this slide is just talking a little bit about what that looks like. But one of the main things I want to focus on is those 3 needs that we're all having as a result of going through chronic stress, connection or relationship building, how to be in a healthy relationship, how to have boundaries and all those kinds of things. Everybody needs to know that in the context of what we just all went through. I have motivational interviewing up there as a specific strategy, but knowing how to empower ourselves and others because we have this need for control right now, heightened. And then the sort of emotion regulation, dealing with what's going on with us inside. So everybody needs that. And so in order to step up in how we're supporting ourselves and each other. And the more we can have sort of the lower level tier things done by people who are not mental health providers, for example, the better. Learning structures that we're finding and the research is showing are really helpful are small doses at intervals that are interspersed with applied practice and self-assessment. So not like what we're doing today, where we sat here for hours talking about this, but a little bit of learning, go out, practice, come back. How did I do with that? That's a very good learning structure, which you could fund in your community. Just in time consultation, that's more like an apprenticeship or on the job training. Reflective practice. So we have, I know a community mental health board that is paying people to work with early childhood providers and so on, to meet with them and say, well, what's it like for me as a person to be doing this work with little kids? How is who I am impacting the work that I'm doing? So that reflective piece. Scheduled sessions for coaching or consultation or supervision, and then kind of communities of practice or professional learning communities. So as I mentioned earlier, we could decide that we're going to step up another level in what we're doing as mental health boards by studying something and learning together. And then the last thing under workforce is human-centered job redesign. The professions that are predominantly women filled, jobs in schools, jobs in mental health, jobs in anything child service related, they're predominantly women. And the pandemic really drove home that the design of those jobs is not working for women. That's why we had this, huge exodus of people. And so thinking about human-centered job design, as you think about a person, an actual individual, and you say, what would make this profession possible for this target individual, and think about their lived experience. So for example, if we wanted our positions that we're funding to be suitable and attractive to a single working mother, have a decent salary, good insurance, maybe even job sharing, where you work part of the time, somebody else works that part of the time on some 40-hour work week. And by the way, research shows you get way more than you would with the one person if you've got multiple people job sharing. Flexible hours and non-traditional schedule. Maybe they don't work in the afternoon when the baby, or they work in the afternoon when the baby's sleeping, etc. Working from home, building in education and advancement opportunities, childcare. I'm going to tell you about one childcare center that I was just in awe. It was actually at the Schaumburg mental health board that I heard about it. This is a childcare setting that has employs young moms as employees. So they're there, their children are there, and they are taking classes during the day while they're getting paid. And what a huge intervention. What a huge intervention that is. So one more slide. If your future self from 8 to 10 years from now could come and join us here right now, what would they want to say to you today? Take a minute to think about that. That future self that was looking at the thriving and flourishing community of your township or county. What would they want to say to you right now, sitting here in December of 23? Who would like to share?
I would say our Illinois Youth Survey, instead of reporting 46% of our children sad, depressed, unhappy, that we would see that number like diminish, period.
So your future self is going to come back and tell you that this is possible, that those numbers on the IYS are going to look dramatically different in 10 years. And how would that make you feel?
I could cry.
Okay,
It's
so
really that emotional, but when you look at those numbers and you see, if you're in our schools and you're talking to teachers and you're talking to administrators, which we are, and just how difficult it is right now, it would. it would be an awesome, happy Pride.
A happy cry. Beautiful. Who else? What do you think your future self would say to you?
People working together to make it whole and not politically driven.
That they would remind you that it's good for people to work together without being politically driven? Okay, nice. Did you have your hand up?
I did. I just wanted to, if, got in line with what you're asking now, but I would like to see funding for that, I call it the ground game. It's that group of folks like these professionals here, but they're out there in the communities, but they don't have the credentials. And that is the group that is actually buying the professionals' time to get to those folks. But they don't have the professional training, but they have the cultural background.
Yeah.
And so that group out there doing that, if there was the professional organization that could, but they don't want to give up their power to the professional organization, because in a lot of ways they're extremely effective. And so I would like to think that there's going to be funding for that. I was at and Deb just enlightened me on the group that I was with that's been showing up at these meetings. But the Juvenile Justice Council.
Okay.
And I was there and I was having this conversation with judge, the district attorney, these professionals, the other group, the state senator that was there. But then you had this other little group that they were saying, well, you know, I got this group that I meet with once a month. It's 15 kiddos. And I got these 25, I got this 30. I just got this big building and I'm doing these things. And so I just got me a part-time job to fund it. But when you look at their credentials, you say, you know, so if this group would use your professional expertise, go down in those areas or connect with folks in those areas. Because it takes courage to go in some of those areas. And maybe a bulletproof vest. But they're down there and they're completely comfortable.
Yeah.
But they need the professional services. But this group down in there, and I can't emphasize it enough because that's what I do. Kind of like that in-between person that can work in a lot of groups. And I work with, you know, professionals. My background is in law enforcement and special education. And so the professionals ask me, hey, can you work with this group? But I don't have that training in that specific area. And so to kind of shorten it, if they would had, you know, and I don't think it takes a lot, you know, it's like 5,000 here, 10,000 there, and just to keep them going, you know, maybe keep the lights on, get them some sandwiches, because they have that conversation and that connection. And what I'm finding out, how these different relationships affect different relationships, so they can be a perfect handoff to these professionals to really get, I think, a higher level of results.
Yeah.
And so this is what I like to see over.
So your future self has a vision that he's sharing with you about how these natural connections in the community that are really supporting the youth could be incorporated and elevated and integrated with all the other efforts that we're implementing to support their well-being.
And this is just a brief back and forth conversation, and just because rather your thoughts on this here. One of the differences is just the language. When I say language, Because a lot of times when we go to a traditional college and you come back and talking to these kiddos, they don't have a clue as to what you're saying. Because, you know, it's just above what they call concept. You have to explain to them what you're saying. Well, this group down here, they have a good grasp on the language. And so somehow connect those two. And I'm kind of using myself as an experiment now, because I go into juvenile detention centers and group homes, and I'm working in a school in special education. And so I do like an after-school program, and I try to pilot this, and then I take that group, and I says, okay, and I go back. So they keep calling me. And, but I don't have time.
Yeah.
I don't have time, but it's very effective. And when I'm talking to each one of you, I'm hearing everyone here talking, and saying, boy, if we can overlap what that person said, what they do, or what they're doing down there, how effective could we be? Now, here's the catch. No one wants to relinquish their power. And therein lies the problem. But you don't have to. You can allow that group to do what they do. And then it's, hey, when you get done, because even the training, because what you're gonna say, the next step is, hey, I want to train you to do this. And they're thinking, you know what? It's not working for you, it's not gonna work for me. But it's working in a different kind of way. So does that make sense?
I hear you.
Yeah.
I hear you.
That's a
You
challenge.
know, I think that in every community, there are these beacons of hope, right? There are programs that are, whether you call them grassroots or whatever you want to call them, that exist. And I guess I just want to highlight the spirit of collaboration over competition. I feel like even in the sort of proposal process and all that kind of thing, to me, it seems like the more resources exist in a community, the greater the competition. In the really, poor areas where everybody knows the only way we're going to be able to do this if we do it together, there just seems to be less competition to me. So I just like to highlight that, the working together. I know that it's 4:03 and you have been so generous with your thoughts today, which has made this super fun for me. And I just wanted to close by saying, for me, when I ask myself, what does it take to be successful in this work? It takes brilliance. We need to have brilliant minds and be able to think outside the box about doing things differently than they've ever been done before. And I always think of the Apollo 11, how failure wasn't an option. They had to get back home and they had to figure out how they were going to do it with what they had on board. And I feel in many ways that's where we are. We have to figure out what we've got and how we can put it together in a way that we get to those Northern Lights. Determination that we never ever give up. We never ever give up. And every time something turns out a little bit differently than we thought it would, that we dig into our data and we learn about it. And we leverage what we learned. Generosity. And this goes to what this gentleman was just saying, that we trust that everyone is doing their best and that change requires vulnerability. And we get further by collaborating than we do by competing. And then finally, to have fun. These are our lives too. And we care about what we're doing so much that sometimes it can be heavy, right? Sometimes it can be heavy, and we need to celebrate our successes and we need to enjoy ourselves and each other and have some fun along the way. Thank you.
Oh, it's on. There's a comment. Okay, let's do that. Thank you so much, Dr. Huber. There might be a question for you before we can. Oh, A nice comment.
Yeah.
Thank you, Donna. Okay, so I'm gonna beg you all to stay for just a few more minutes. I can make it quick. But we're gonna kick Jody out.
Yep, I'm gonna get my computer, I'm gonna end the Zoom for the, I mean, are you gonna leave the Zoom? I guess.
No, it's okay. Like, thank you all for participating on Zoom. Hopefully we'll see you in the morning too.
Thanks, everyone.
I don't think we should have a recording.